of Internal Medicine, and I'm very pleased to be here with Pamela Gordon, who'll be giving the second half of this lecture. We're going to be speaking today about patient safety and just culture. So this is the first in our quality and safety lecture series. In December, we'll be talking about quality improvement tools, including lean methodology. In February, we'll be talking about root cause analysis. In April, about high reliability organizations and error prevention. And in May, we'll talk about the ABCs of quality metrics. It is an ACGME requirement that we teach residents and fellows about quality and safety, and we hope to touch on many of these clear program objectives through this lecture series. So today we'll be talking about the science of safety, in particular accident causation. We'll talk about the scope of the problem of errors in healthcare. We'll go over some key definitions, speak about ways in which we can improve, and then we'll talk about just culture and event reporting. Objectives today are to be able to describe the Swiss cheese model of accident causation, to understand the scope of the problem of errors in healthcare, to define error, harm, and near miss, to understand the concept of just culture, and finally to explain how to submit an event report at Erlanger. Complex systems such as rail, air, space travel, nuclear power, chemical manufacturing, and healthcare are intrinsically hazardous. They routinely run in degraded modes, meaning they operate under stress or under suboptimal conditions. They contain latent errors built into processes, and they're prone to human error. To prevent catastrophe, multiple layers of defenses must be built into systems. In 1977, the world saw the worst air disaster in history when two 747s collided on Tenerife Island. I'd like you to listen as John Nance, who's a pilot and aviation safety specialist, speaks about this disaster, and listen for parallels to some of the conditions that we operate under in healthcare.
Jacob, this particular day, is a very upset guy. The reason he's upset is because he's had to divert into a place he didn't want to go. See, the chief pilot has to fly every now and then, just like the director of the medical staff has to stay current. And he's gotten out and gone in a 747, and he's taken this charter down to the Canary Islands, and he's going to turn around, pick up another group of passengers, take them back to Amsterdam, then he'll get off, go back to the office, and somebody else will fly the airplane on. Except it's not working that way. Murphy has gotten in the works. And there's been a bomb threat over at Las Palmas, which is the main airport of the Canary Islands, so he's had to divert along with several other airplanes to another airfield at slightly higher altitude, only one runway, it's kind of short, and is fog-bound today. It's not really fog, it's clouds blowing across the runway, but it's just the same. He's had trouble getting his fuel, he's had trouble getting out of there, and he's about to run out of a thing we call crew duty time. This is the maximum amount of time that an air crew may remain on duty before we've got to put them to bed to get them some rest. I know this is a completely foreign concept to healthcare. But anyway, Jacob is an upset guy this day because he's finally gotten his airplane started. He has 10 minutes to get this huge 747 to the end of this fog-bound runway and get off the ground without running out of crew duty time. And here's the penalty. If he runs out, he's got to put everybody to bed at Las Palmas, buy $30,000 worth of hotel rooms and delays, and it's going to be very embarrassing. So he wants to go, and as they get the airplane down the field, they have to taxi down the runway about halfway because there are no taxiways stressed for a 747 at the first part. Then he has to turn around, get on a taxiway, come to the end, turn around, line up with the runway. They can only see about 300 yards into the fog. And as they line up, the first officer, who is very senior at KLM but very junior to Jacob Van Zanten and has never flown with Jacob before, and the second officer, who's very senior at the airline as a second officer, hyphen flight engineer, but very junior to the first officer, who's very junior to the captain. You get the hierarchy? As they get in position, the first officer, co-pilot, sees the captain's right hand coming forward on throttles for these four huge JT9D engines, 50,000 pounds thrust apiece. And he knows that they don't have a clearance to take off. On top of that, they don't have what's known as an air traffic control clearance to actually go over to Las Palmas. And he turns toward his commander with wide eyes and says, "Sir, we don't have a takeoff clearance." And Jacob Van Zanten pulls the throttles back, and in the inimitable fashion that all of us who qualify as airline captains learn, he says, "I knew that. Get the clearance." First officer punches the button, talks to the tower, asks the clearance. Clearance is read to him. He reads the clearance back. We have a little linguistic disconnect here because the guys in the KLM cockpit speak Dutch. That's their native language. And yet they're communicating by radio in a thing we call aviation English, which is kind of a stylized version of English. The fellow in the tower is Spanish because this is a Spanish possession. He is trying to communicate in another language, aviation English. There is even an air crew on the field moving around out there who, according to my British friends, don't speak English at all. Pan American. I'm told we speak American. We don't speak English. At any rate, there is a linguistic disconnect, so when the first officer is finishing his readback and notices with increasing horror that the captain's hand is once again coming forward on the throttles, because they have now the air traffic control clearance, but they still don't have the physical clearance to take off. These are two separate clearances required. By the way, this guy is not a dummy. This is not a dumb individual. This is you or me sitting in that right seat. This is everybody in this room who has ever been in a position to see a senior individual doing something for the second time, and you got by with it first. You were well treated when you pointed it out the first time. Do you really want to tell them again that they're fouling up? He would like to find another way to do it. So the first officer, knowing that the captain is starting the takeoff roll without permission, keeps his finger on the transmit button and says, and we are at takeoff, KLM 1422. But the problem with this is that it doesn't make sense in aviation English. We are at takeoff. But as we all want to do as human beings, we fill in the blanks, don't we? You expect to hear something, and it's close, so you just go ahead and fill in the blanks. We are at takeoff. We are in takeoff position. Yeah, that'll work. That's what he means. We're in takeoff position. However, there's something wrong, and the tower controller is not really satisfied with this. And the controller presses his transmit button and says, okay, stand by, KLM, I will call you. But before he can get the second part of that phrase out, somebody else who's worried transmits, and the two transmissions cancel themselves out, and the only thing heard in the headsets of the KLM crew is the word okay. Set power, says Jacob. Vigo. Now the first officer's attention is entirely skewed to serving his commander as this big jet begins to roll forward into the fog. 5 knots, 10 knots. 20 knots. There's another radio transmission out there someplace on the air patch, and the first officer and the captain are too busy with the takeoff roll to really pay attention to it, but the second officer, flight engineer, the guy who sits side saddle, he hears this and it worries him. And he leans forward at 35, 40 knots and says, is he not clear then, that Pan Am? 50 knots, 55 knots, 60 knots. What? Says Jacob. Huh? Says the first officer. 65 knots, 70 knots. Now in a more timorous voice, the second officer leans forward and says, is he not clear then, that Pan Am? 75 knots, 80 knots. Yes, says Jacob angrily, unhappy to be interrupted in the middle of his takeoff roll. Yes, echoes the first officer, and the second officer sits back, shuts up, says no more. 90 knots, 100, 105, 110, 112 knots. They finally come out of the wall of fog, and they can see ahead. What they can see is the worst thing an airline captain can possibly imagine. Another airplane sideways on the runway right in front of them. Pan Am had not left the runway yet. Van Zanten pulls the yoke into his chest as hard as he can. The airplane's nose comes off the ground. He beds the tail in the concrete. 50 yards of sparks as the big bird begins to lift off the ground. It's 25 knots too slow, and yet he leaps it off the ground, and for a moment it looks like he's going to make it. The huge Pan Am logo slides past the left side of the peripheral vision of the cockpit. The nose gear passes safely over the back of Pan Am, but the body gear and the wing gear don't make it. They bite through the back of the structural integrity of the other 747. Its wings fall to the ground in flames. It comes apart. KLM's undercarriage is ripped away from it along with 40 knots, and it falls back to the runway in flames. And within 30 seconds, 572 human beings lose their lives. 572.
So why do accidents happen? James Reason is a well-known British psychologist and expert in human error and system safety. And he wrote an article in the BMJ in 2000 called Human Error Models in Management. And in this, he described a person approach to accident causation versus a systems approach. So a person approach focuses on unsafe acts, which could be errors or procedural violations committed by frontline staff. These are viewed as the result of faulty mental processes, such as forgetfulness, inattention, carelessness, negligence, and corrective actions are focused on eliminating unwanted variation in human behavior, eliminating these faulty mental processes. This can include naming, blaming, and shaming, writing new policies, retraining, and promoting fear of disciplinary measures. So if we apply the person approach to the Tenerife disaster, we could say the KLM pilot initiated takeoff without clearance and is primarily to blame for the disaster. Since he died and will no longer be flying, an accident like this will never happen again. This can be emotionally satisfying. It's human nature to want to find someone to blame. And this might free or limit the organization from liability. This was the dominant approach in aviation prior to this disaster in 1977. But there's a troubling question. Jacob Van Zanten was the chief pilot and safety officer. If he could make this type of error, would other pilots not be at risk if faced with the same conditions? I'd like for you to listen to John Nance one more time.
And what was our response in aviation? We had all feared a jumbo jet accident. But two of them together on the ground? But it wasn't that. It wasn't the horror of the numbers. It wasn't the impact of the fact that this happened on the ground, or that it even happened to KLM and to Pan American, two of the best in the world. What got us was this simple fact. There was nothing mechanically wrong with any of those airplanes, either of those airplanes. There was no 39-cent light bulb we could blame. There was nothing to blame except the carbon-based units on board KLM. And that was our normal game, wasn't it? Just like healthcare. What do? We find the miscreant and we get rid of him or her. We take the action to make sure that individual can't do it again. Well, Jacob wasn't going to do it again. He was dead. But our problem here was very profound, because in order to be able to chastise in absentia, to be able to say that our problem here was this bad pilot, this bad doctor, this bad nurse, we have to justify the fact that we're talking about the best and the brightest. We're talking about the chief pilot. As a matter of fact, when the call went out in Amsterdam from the CEO of the organization to get the director of safety and get him on board an airplane and send him to Tenerife, remember the name now, Tenerife? When the call went out, the call came back within about 5 minutes, and a subordinate with a shaking voice said to the CEO, "Sir, we can't do that." He says, "Why not?" He says, "Because the director of safety's name was Jacob Van Zanten." We could not get by with this accident by simply saying that it was a bad captain, it was a bad pilot. We had to recognize the fact that we had a systemic problem.
So in contrast to the person's approach, the system approach assumes that humans are fallible and errors are to be expected even in the best organizations. Systems are prone to error-producing conditions, and errors are a consequence of system failures rather than individual acts. Corrective actions are focused on why system defenses failed. So in this diagram, you can see that there are latent conditions, which might be suboptimal management decisions and organizational processes. These lead to triggering factors, which may be error-producing or violation-producing conditions. And then these trigger unsafe acts or omissions, which are errors or violations. And if defenses are bypassed, this can lead to an accident. So in the Swiss cheese model of accident causation, which was put forward by James Reason in 1990, the slices of cheese are layers of defense, and the holes are latent conditions or active failures. Latent conditions are defects in the design or process of systems, and active failures are unsafe acts, which can be errors or violations. If the holes align, defenses fail, and an accident can occur. So if we apply the Swiss cheese model to the Tenerife disaster, we can tell that there were multiple latent conditions that ultimately led to the active failure. These include diversion to a smaller, unfamiliar airport, heavy fog, crew duty time pressures, language barrier leading to problems with communication, a strict hierarchy where it was difficult to speak up. And you can imagine that if any of one of these latent conditions were not present, if any one of these holes were filled, it would be unlikely that the protocol violation of initiating takeoff without clearance would have occurred at all. So I'd like to pose a question. Which is riskier, flying with a commercial airline or receiving treatment in a hospital? Who would say flying? All right, who would say receiving treatment in a hospital? All right. Well, we all work in healthcare, so you're all correct. But I think many of our friends and family who don't work in healthcare would be very surprised to learn that going into a hospital is far riskier than flying. This is an article from Reuters in 2011. And at that time, Liam Donaldson was the WHO's newly appointed envoy for patient safety. And he said the following: if you were admitted to a hospital tomorrow in any country, your chances of being subjected to an error in your care would be something like 1 in 10. Your chances of dying due to an error in healthcare would be 1 in 300. This is compared to a risk of dying in an air crash of about 1 in 10 million. How could this be? How could aviation be so much safer than healthcare? Well, aviation has been working on safety for almost 100 years. Aviation started using simulation in 1929. They started with checklists in 1935. And the first error reporting system, called the Aviation Safety Reporting System, was developed in 1976. Teamwork training, which they call crew resource management, which largely came out of the Tenerife disaster, was formally started in 1979. Healthcare is decades behind. In fact, the birth of the modern patient safety movement is not even thought to have occurred until 1999, when the IOM released the To Err is Human report. And this report, as you may know, estimated that between 44,000 and 98,000 Americans die each year from medical mistakes. And this was extrapolated from the Harvard Medical Practice Study and a similar study of patients in Utah and Colorado. And this was at a cost estimated between 17 and 29 billion. But shortly after the release of To Err is Human, many safety experts came out and said that that estimate was actually underestimated. Most recently, in 2016, Mauri Meharry, who's a prominent pancreatic surgeon and chair of surgery at Johns Hopkins, as well as a safety expert and one of the fathers of the safe surgery checklist, he published an article in the BMJ where he concluded that medical error is the third leading cause of death in the U.S. To come to this conclusion, he pulled results from 4 large studies since 1999 looking at U.S. death rates from medical error. You can see the percent of admissions with a preventable lethal adverse event in this column, and taken together, he felt that this percentage was 0.71%. And then when you extrapolate that to the 2013 number of admissions to U.S. hospitals, you get a rate of 251,454 patients with a preventable lethal adverse event. So he concluded, when comparing this to CDC data, that medical error is the third leading cause of death in the U.S. in 2013, behind heart disease and cancer. And he notes that we're not even counting this. We're not even recording medical error on death certificates. So let's go over a couple of key definitions. The first is error. So an error is either an act of commission or an act of omission, either doing something wrong or failing to do the right thing. And it's important to note that most errors do not lead to harm. Studies have estimated that ICU patients face 1.7 errors per day, and about a third of those could potentially lead to harm and serious injury. It's estimated that the average medical patient in the hospital experiences 1 medication error per day. Harm, or an adverse event, is unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization, or that results in death. A near miss is an error that could have caused harm, but harm was avoided through chance or vigilance. The error was caught in time. This is the iceberg model of medical errors, and here you can see that serious harm or death is only the tip of the iceberg of medical errors, that many more errors actually do not cause harm, and others are near misses. This is a popular index for categorizing errors. And you'll see this a lot if you work in patient safety or you come to a conference regarding patient errors and events. And you'll notice that the categories go from category A to I. Category A is just unsafe conditions. Category B through D are events that are errors that don't cause harm. Categories E through H are errors that cause harm to the patient and increasing severity. And category I are errors that cause death. So how can we make care safer? Well, we can design safer systems. We can use human factors engineering to simplify, to standardize, to use forcing functions, to make it hard to do the wrong thing. We can use checklists, like the safe surgery checklist, or the central line insertion checklist, which actually decreased the rate of CLABSI in this country by 80%, saving hundreds of thousands of lives. In fact, many hospitals have actually gotten to 0 CLABSI events through the use of this checklist. We also need to improve teamwork and communication between attendings and residents, between physicians and nurses, and all members of the healthcare team. We need to report and investigate errors so we can find the defects in the system and correct them. And we need to put all of these things together to cultivate a culture of safety. Our goal should be 0 harm. And with that, I'd like to introduce Pamela Gordon, who's the Vice President for Patient Safety and Quality for Erlanger Health System. And I'm so happy that she's partnered with us to teach residents and fellows about safety and quality. She brings a wealth of experience and knowledge, so thank you so much.
Thank you. Thank you. Good afternoon, everyone. Can everybody hear me in the back? Okay, thank you. Dr. Jackson says yes, he can hear us in the back. I just want to thank you. I've been here with Erlanger for about a year, and I'm often asked, what is your opinion? What do you think it's really going to take for healthcare to be safer? And my response is always 2 things. One, education, communication, and systems that really drive what Dr. Wooten just said, making errors more difficult to produce. And then 2, looking at faces around the room, you're the face of change. So each and every person in this room, at this point forward, you have the responsibility, the ability, the ownership to really make the system safer by being willing to speak up and speak out when you see situations, processes that don't quite connect or click. It's your responsibility, all of our responsibilities, to help make Erlanger and healthcare a safer place. And I really appreciate the opportunity to present. Thank you so much. Some thanks for some slides. So what is a just culture? The patient safety net has a definition that I really embrace. It talks about active errors. Traditionally in the past, healthcare has been a naming and blaming type of culture. A just culture means that we transition. We understand that there are human factors. We understand that to err is human. None of us are perfect. Even on our absolute most perfect day, the 80-20 rule comes into play, and we are 80% effective versus 20% that would allow error to occur. The culture that touts a no blame, though, I would have to say, does not turn a deaf eye or a deaf ear, a blind eye or deaf ear. So if error is consistent, repetitive, then there is accountability and responsibility to fix those errors. A just culture recognizes that competent professionals make mistakes and acknowledges that even when competent professionals do make those mistakes, like we just talked about the plane crash, unhealthy norms can actually occur which allow that Swiss cheese effect and process violations. We're going to talk about that. Just culture does have a 0 tolerance for that reckless kind of behavior. So 3 types of behaviors: normal behavior, at-risk behavior, and then reckless behavior. And you can see at the bottom, you can see at the bottom the management approach to that type of behavior. So a normal error would be inadvertent action. So a slip, a lapse, I didn't mean to make this error, I didn't know, I was tired, an error was produced. And we would approach that or manage that through maybe a process change, maybe a procedure change, maybe something in the procedure language was unclear, and we certainly want to offer support to the staff member, to the employee. And at-risk behavior is a definitive choice. It's very discrete and clear. The risk is not recognized, or maybe I personally, because of my upbringing and my life experiences, maybe I don't personally believe that that process or that procedure step is necessary. So I don't find value personally in that step. And so I'm going to make the choice not to follow whatever the process or procedure. Those type of actions we need to manage through removing incentives for that at-risk behavior. We need to create incentives for healthy behavior, so recognize the positives. We also need to increase situational awareness, and certainly the approach would be a coaching approach for the staff member in those types of errors. And then we have the third category, which is reckless behavior. My opinion as a quality professional, I don't see this very often because I believe people in healthcare come to work to do the right thing. So I very rarely see the reckless behavior. But that's defined as a conscious disregard of an unreasonable or perceived unreasonable risk. Those have to be managed through sanctions, punitive or remedial actions. Here you can see this pretty comprehensive algorithm. So in a culture of a just culture, a culture of safety, there's a perception even here, I'll be transparent, that I may not want to event report because someone's going to get in trouble as a result of that event reporting information. I can tell you I have not seen that happen here. We make every effort to follow this algorithm. And as you can see, there are lots of different outcomes at the bottom. It could be a blameless error. To my knowledge, since I've been here, I haven't seen an issue, a situation of sabotage. So again, it's just an algorithm for a thought process. Every event goes through a very similar, very conscious process to determine how the error occurred. Was it blameless? Was it human factors? Human factors would lead us down an engineering systemic type of process fix or solution. Questions on the algorithm while we're here? Has anyone seen this before? No, a couple people. Okay. I think it's important to note, too, that crisis management or error prevention, safety prevention, and culture, it's a journey. It's not a one and done. It takes a long period of time. Changing a culture takes 3 to 7 years, and I believe that the same is true for creating a culture of safety. We're certainly not at the bottom. We're not at the pathological box here at Erlanger where let's see, I think it says, who cares as long as, we're not impacted, kind of the who cares, loose kind of attitude. We're certainly not there. We sit sometimes in the reactive box. So firefighting, something's happened, we're investigating the event, we're pulling the timeline, we're doing the root cause analysis. So some of our work is reactive. But I'm happy to say that we've moved to some degree, as Dr. Jackson would say, into the high reliability organization principle of calculating and predicting our risks. So we're kind of moving through that culture and up the ladder. Our goal is to become more proactive, to be absolutely predictive in where harm can occur, and to put systems in place that prevent that harm or at least mitigate the risk involved, and then generative, to the point that we are absolutely predictive, preventive, we can anticipate error and remove the opportunity for error before it's incurred. So interesting to me that a just culture is very difficult. Two separate buckets of responsibility. The individual's responsibility is really just the decision to follow whatever evidence-based best practices or protocols are in place. That's the number one responsibility when we're looking at error and error prevention or digging into a root cause for an event. The organization has a lot of onus and responsibility too for us, the patients, but to the staff and the physicians as well. So we have as an organization the absolute responsibility to make sure that our practices and protocols are evidence-based and they are the latest and greatest information based on research on proper patient treatment. Tools, information have to be available for our staff. Standardization and innovation. we have to continually innovate, and that's why research is so important in those new practices. Focus on process improvements. One of the opportunities that we have for a resident and a physician group specifically is when we do event report, there's a lot of work behind the scenes, a lot of work and formal root cause analysis processes. My goal is to close the loop, so to speak, such that if an event is reported by a resident, that the corrective actions and the process changes that help mitigate risk going forward that allow that harm to occur, that information comes back to you as a resident who entered the event so that you have full circle visibility, transparency, and closure so that you know that the information that you entered, it really was valuable to help make the system safer. The organization is responsible for creating an environment of trust. Of course, we have to provide an avenue or a process to event report, and then a structured process for root cause analysis. So I wanted to share a personal experience from previous organization around norms. Just culture, we had been on the just culture journey as an organization for maybe 4 years. In my quality role, previous organization, I was reviewing an event that had a wrong medication. It was a medication administration error. Went through all the formal process, root cause analysis, talked to the staff, talked to the physicians. Ironically, 2 days later, same situation occurred again. Same unit, different person. So again, we're escalating now. Senses are heightened. Long story short, we had a situation where we had HIV exposures. Staff, a norm or practice allowed within several units of the hospital was to carry medications, syringes, different vials of medication for different patients in smock pockets and carry those around. So they weren't immediately taken out of Pyxis, immediately administered, did not happen. And everyone would shake their head. We interviewed everyone, almost 300 people. Everyone knew the protocol. Everyone knew the standard practice. Everyone knew what was documented as far as procedure. But what we heard was, well, that's not I know what the process says. I know what the policy says. But that's not how I was trained. And when I'm in a hurry, I have to figure out which shortcuts to take. And so carrying several different medications in my pocket is the way that I can quickly make rounds on all my patients. So the point that I want to make is, in this situation, it wasn't we talked about the Swiss cheese lining up. In this situation, it was just a slow drift. It was a slow fade. One person varies a little bit from the evidence-based practice, and you have another person drift a little bit. We had preceptors actually sign off on all the training, all the education. But at the end of the day, we had 6 patients that were exposed and given injections from needles that were from HIV patients. And so we had to disclose. So it can happen. It can innocently happen. We have to be guarded. IHI defines a culture of safety as an environment in which providers can discuss errors, near misses, and harm openly, knowing that they won't be unfairly punished or have confidence that reporting safety events will lead to improvement. So just by show of hands, quick question. How many people like to or find pleasure in admitting to your spouse, significant other, loved one that you've made a mistake in anything? You go to the grocery store, you need 3 things, you come back with 7, and 2 of them on your list you didn't get. You make a wrong turn, you're traveling somewhere, I see people laughing. Does anyone like to admit that? We all make mistakes, right? We all make errors. The point that I want to make is it's as humans, it's difficult for us as people just to admit that we made a mistake. So it's exponentially more difficult in a healthcare setting where we have the vocation that requires us to be responsible for the care of others. It's that much more difficult for us to talk about the errors that we make. But it's crucial to preventing those errors from occurring. So why you? Why residents? Why is this so important? You guys collectively, you have firsthand information, firsthand knowledge. you're fresh, you haven't been here so long as to have those cultural norm drifts that I talked about. Fresh eyes, fresh perspectives, absolutely critical to our safety program. Timeliness. If you're involved in a situation where a medication was delayed, wrong medication, or maybe a near miss, if you don't immediately report that, the next person behind you may not report as well, and that period of time is a safety risk gap. So by not reporting as soon as you see the error, potential error, you're making the decision, unconscious decision, that it's okay and that opportunity for error can continue to occur. So it's really important that you let someone know. And then we need to take actions to fill those process gaps. So there are 3 different kinds of actions that I want to make you aware of. Timeliness is important because the first action is a containment action. And a containment action is likened unto a Band-Aid. If someone gets cut, the Band-Aid is the immediate fix. It stops the bleeding. But it doesn't necessarily remove the knife or the sharp instrument that allowed the cut to occur. So in quality, we really have to focus on what is the containment action, how widespread is this, is it all patients on medicine 3,000, is it 2 rooms, 3 rooms, is it just at East, or is it enterprise-wide? Corrective actions are just that. So they're actions that understand, based on a well-defined problem statement and a root cause analysis, what allowed the event to occur. So they truly do correct the problem. It's not a quick fix, and it's not just an intermediate fix, but corrective actions are absolutely preventing that or a similar event from ever occurring again. And so the opportunity here is to take our corrective actions and to put them on steroids and to make sure that they are systematized so that they're hardwired and they do not recur. And then preventive actions. So if I had a situation, my previous employer, with medications and syringes being carried around in pockets and maybe being swapped out for patients that were not supposed to get that medication, what other preventive actions might I look at? I can look at other types of medication administration, right? Not just insulin. I can look at how other medications were pulled from the Pyxis to ensure that the gaps that allowed this process and culture drift does not occur for other medication administration as well. Does that make sense? Okay, so 3 types of error. So event reporting, how and why. We currently use a system called eSafe for our event reporting. Has anyone entered an event and used eSafe or seen eSafe? A few people, okay. It's very simple to use. And why, just like we've been saying, Dr. Wooten alluded to as well, we really want to analyze the process. So it's not about blaming, absolutely not about shaming. It's about understanding why the process is weak or has a gap so that we can improve the process. We want to make sure that we eliminate, reduce, or eliminate the same type of error in that location or the same type of error in other areas or areas related before they occur, and that's that preventive action that we talked about. I wanted to tell you, too, that whenever you enter an event in eSafe, as part of a patient safety organization, Erlanger is part of a PSO, and pursuant to Tennessee state law, information in eSafe is absolutely confidential and is protected. So conversely, if you put it in the patient chart, it's not protected from litigation. If you email or text, I guess Tiger Text is the exception, but if you email, it's not protected from litigative circumstances. But eSafe, it is protected, and it's considered patient safety work product. So it's a safe place to house that information. So this is our intranet, and if you'll see on the right as you open up the page, there's an application links. So eSafe is just the link, it's the 4th one down. It's easy to find. And when you log in, it's the same as your username and password, your network username and password. There is an option on the bottom, you'll see down there, number 5. You can submit information unanimously. I don't encourage you to do that. One, it doesn't speak to we are transparent and we have a culture of safety and we want to talk about errors that have occurred. And 2, if I need additional information, I have no one to follow up with to get that process information that may be critical to the corrective action plan. So I would encourage you to use your username and log in. If you need to submit anonymously, just give as much information as you feel pertinent to the situation. I won't go through this, lots of different categories. If you don't see the category that really applies to your error or speaks to it well, it doesn't matter. You can put it in and then we'll move it. You can pick any category. If we see that it doesn't align on the back end, we'll put it in the right category. We'll classify it for you, so don't get hung up on that. So what happens when an event is entered into eSafe? I've had this question asked quite a bit. It seems like maybe from the front end it goes into a black hole and you don't hear a lot about it. There's a lot of work on the back end for each and every event that has been entered. Immediately, the information comes to myself and all of my quality team. So we're notified immediately within maybe 2 seconds. So when you hit submit on the event, we start the event review. We want to focus on the process, so we start gathering all those process details. We get the chart, we go into the chart, and start to put together a timeline. Simultaneously, while we're putting together a very discrete timeline, a clinical timeline, we also talk to the staff, anyone else that may have experienced the situation, the event. Sometimes it's another patient across the hall, sometimes it's the patient family, it just depends. But we really want to get those recollections because we feel like that's important. That's additional process information that we may not be aware of just by reading the clinical timeline. We then proceed to do a causal analysis, and there are time parameters around all of this. Within the first 24 hours, we try not to pull a group of people together. If it's been an adverse or serious or harmful event, we really want to focus that first 24 hours in gathering process information and spending time with and supporting the person or persons who were involved. And we call that second victim, but that's our focus in the first 24 hours. So we move on to causal analysis. We either do a parent cause analysis or root cause analysis. Root cause are those more serious or sentinel events, or it could be like the HIV exposure. It could be we've had multiple events, and so we will bump that up from an apparent cause to a root cause analysis based on magnitude and scope. Then the appropriate process corrective actions are set in place with discrete owners to mitigate that risk. And of course, we talked about second victim program. Is everyone aware of our second victim program? Anyone? So if you or one of your colleagues have been in an adverse event where an error has occurred, we do have a resource for you in our psychology department, psychology department. Dr. Jenny Mahaffey is happy to see you. We've worked out the copay with our human resources department. If it is work-related, and you have an event that you need to speak to someone to get that support, we have a process for you. You can see myself or Dr. Wooten. Either one of us would be happy to help you. Questions on this slide? So human factors and due diligence. I think it's important to know that we are humans. We aspire to be perfect, but none of us are. And we have the responsibility to hardware systems. We Band-Aid well. You know, we have a problem, we Band-Aid it, temporary fix. Another problem, Band-Aid it, temporary fix. Those don't work. Those Band-Aids come off, and then you have a bigger, more systemic problem. It's exponentially important that with our corrective actions, we start to understand how do we hardwire systems so that error is absolutely corrected and prevented from occurring again, despite our human tendencies or human error. Absolutely critical. And we must exercise due diligence to make sure that processes are robust. So in your work, in your day-to-day activities, if you feel like a process is maybe unclear, don't have clear direction, I don't know the policy's vague, ambiguous, please enter that in eSafe and let us correct that. We want to correct that. And of course, none of us should ever say or tolerate, we've always done it that way. Should not be part of our vocabulary. So currently, our event reporting structure, we've had some improvement in the past year. So that means we're working toward like that ladder, that continuum of having that just culture. We've increased by about 34% our event reporting in FY17. I do want you to know we have what we call a Great Catch program. So I would ask you to not just enter events that have caused error, but if you see a colleague, a nurse, physician, someone doing something really well that you feel is stellar, that maybe has prevented an event from recurring, please enter that information in eSafe so that we can recognize. And we do recognize at Quality Oversight Committee. Process gaps, I think we're starting to see them as opportunity, but we still have some work to do there. And then process trends and recurrences, we're implementing a new root cause analysis software that will allow, as I said before, allow that information to come back to you as the owner, the initiator of the event, to know what exactly changed as a result of your event reporting. A little bit about IHI's RCA squared model. That's what we'll be using going forward. Focus on action. Questions for me? Yes.
Thank you. I had a couple of questions. One, if the complaint to eSafe is not anonymous, how is that loop closed?
If it's not anonymous,
Yes, suppose there is a complaint made, how is feedback given to the person who, that is one question, and just out of this increase that you have shown here,
Yes.
what percentage of these are anonymous, anonymously reported? I mean, that would give
Yes.
culture prevalent.
Yes, we don't have a lot of anonymous reporting, actually. I'm thankful to say. I think it's less than 7%, which is very good for our organization. Right now, that feedback loop is in the form of an action register. And so if you're assigned an action as a result of an event, you'll get a copy of that event's action register and all the actions that pertain to that event. It's loose, though. It's not a real firm structure or system. It's myself or Jackie Bishop remembering to send a copy of that action register to you. So it's not systematized, is what I'm saying. It's not hardwired. With the new module, the new RCA squared module, it will be electronic. You'll have complete visibility of the event and the progress on the action items and who they are assigned to for ownership as the event initiator. So I think that will give us great transparency. Also, we'll be able to pull reports and trends, which I think is helpful. So if we want to know how many level I serious events have happened in a particular area and what are the 3 top process changes that have been impacted, we'll be able to pull that data. So it will give us much greater visibility in the system overall. That was a good question. Thank you. Yes, sir.
Our third clear visit is coming anytime after January 1st.
Okay.
Will that feedback mechanism be up and running by January, February?
So the RCA squared module will not be. We also have a new feedback or complaints module that will be, where we can recognize staff. It's kind of a staff recognition program as well. So one module will be, the other will be right in the middle of transition. So we'll still be on the old system per se, the current eSafe, in January until probably the first week in February. So it depends on when they come. But we can show them the Gantt chart, the milestone schedule, and we have kind of a comparison table, a crosswalk, if you will, so that they can see the differences between like version 6.3.3 and version 7.3. We can show the difference. You're welcome. Any other questions? Yes.
I think it would be great to really stress to the residents the importance of the second victim program. Certainly, and the pediatric residents have heard me say this, but we have seen many times when residents think it's a sign of weakness if they have to go talk to somebody or if they've had a particularly traumatic event. And we believe that in pediatrics that it's absolutely necessary. If you go through one of those events, that you have a chance. And that includes nurses, attendings, and residents.
I completely agree. And I'll just give you a personal example. As AOC, a few AOC rotations ago, I rounded in the morgue. I don't know why, but I always round in the morgue. And the coolers were full. There were 2 bodies outside the coolers. One of the bodies was fresh. There was a lot of blood on the bed. Opened up. I looked to see, okay, maybe there's a cooler that's empty. So I put on my gloves and started opening up the cooler doors to make sure that maybe this one body could go into a cooler. The first cooler I opened had a body in it. It was a young man, about the age of my son, so I'm already, traumatized. I'm thinking about that. The body bag was not zipped up, so he was half in the body bag, half out of the body bag. It was a trauma victim. Someone had brought a tennis shoe and placed it on top of his neck. And I remember thinking, I would never get over the fact if this were my son and I were coming to identify a body. And so this is just not appropriate. So I pulled the tray out, tried to get around, tried to get him down into the body bag. And, it was a messy situation. I ended up getting some blood on my sleeves and on my gloves, and finally got the body bag zipped up. But by the time I finished, I was crying and very upset. I'm just being honest. And so even in that situation, I had a couple of dreams about it. Didn't think it would really impact me the way that it did, but I was very upset about that. That should have never happened. We should have had more grace than to treat a patient alive or deceased than that situation. And so actually I have used the program just because of that, because I knew the event happened, I couldn't shake it. So that's the key. If you're involved in a situation and it keeps coming up in your thought process, you dream about it at night, you just cannot shake it for whatever reason, I would ask you, please seek out this service, because it's very helpful. And we need to stay whole and healthy as a group of professionals so that we can treat our patients. Thank you, Dr. Court. That's a good point.
And sometimes it's not even just the death of the individual, but it's also the reaction of the family.
Right.
Different cultures react differently to a loved one dying.
Right.
And with the school bus accident, a lot of us got a real taste of what that was all about. So, never underestimate how much it can affect you personally.
Absolutely.
We feel we need to be professional.
And if you see a colleague struggling, please recommend. It may not be you. It may be one of your peers, one of your colleagues, but recommend their service. I would highly recommend. Any other questions? Thank you very much for your time. I appreciate it. Thank you. Do you shut this all the way off? Do you shut it down or leave it on?
I think they'll take care of
Okay.
it. Yeah, thank you.